Today we're going to talk about anaphylaxis, what it is, how it happens, how it shows up in patients, and what nurses need to know about prevention, management, and patient education. Anaphylaxis is a type I hypersensitivity reaction, which means it's IgE-mediated. In simple terms, the body meets an antigen. The IgE antibodies latch onto mast cells and basophils, and those cells suddenly dump out a flood of chemicals like histamine, prostaglandins, and leukotrienes. That flood causes vasodilation, swelling, airway narrowing, low blood pressure, and bronchospasm. Symptoms usually come on suddenly, and they can go from mild to life-threatening in minutes. There's also something called an anaphylactoid reaction, which looks very similar but doesn't involve IgE. Instead, mast cells and basophils release chemicals because of non-IgE triggers like medications, food, exercise, or blood products. These reactions may be local or systemic, and while they can be serious, they're rarely fatal. The important thing for us as nurses is that treatment for anaphylaxis and anaphylactoid reactions is essentially the same. Now, let's talk about common causes. Foods are a big one. Peanuts, tree nuts, shellfish, fish, milk, eggs, soy, and wheat are the classic culprits. Medications are another major category, with penicillin at the top of the list, along with sulfa antibiotics, contrast dyes, anesthetic agents, and NSAIDs like aspirin. Other triggers include animal serums, vaccines, insect stings from bees, wasps, hornets, and fire ants, and latex products. So what does anaphylaxis look like in real life? Clinical manifestations can be mild, moderate, or severe. Mild reactions may just be tingling, warmth, nasal congestion, watery eyes, sneezing, or a feeling of fullness in the throat. Moderate reactions can add flushing, itching, anxiety, bronchospasm, cough, and wheezing. Severe reactions are abrupt and progress quickly. Patients may develop laryngeal edema, severe dyspnea, cyanosis, low blood pressure, abdominal cramping, vomiting, seizures, and even cardiac arrest. The key thing to remember is that the faster the symptoms appear, the more severe the reaction is likely to be. And just because someone had a mild reaction last time doesn't mean the next one will be mild. Because anaphylaxis can be unpredictable and severe, prevention is crucial. Patients at risk should avoid known allergens whenever possible, whether that means reading food labels carefully, avoiding insect-prone areas, or wearing protective clothing. For patients who are at higher risk, an epinephrine autoinjector is prescribed. They should carry it with them at all times and know how to use it. Screening for allergies before giving medications, especially IV or injectable drugs, is another important preventive step. Patients should also wear a medical alert bracelet or necklace to identify their allergies. Some patients benefit from special therapies. For example, people with insect venom allergies may undergo venom immunotherapy, which reduces the risk of severe reactions to future stings. Others, like patients with insulin or penicillin allergies, may go through desensitization protocols, which gradually introduce the allergen in controlled doses. When prevention fails and a reaction happens, medical management is focused on rapid action. First, assess airway, breathing, and circulation. If the patient is in cardiac arrest, start CPR. Give supplemental oxygen if the patient is short of breath, wheezing, or cyanotic. The cornerstone of treatment is epinephrine. It's given in a 1/1000 dilution subcutaneously in the thigh or upper arm. In severe cases, it may be followed by a continuous IV infusion. Adverse events from epinephrine are most likely when the dose is too high or given intravenously, especially in older patients or those with heart disease. It's important to remember that epinephrine is the priority. Antihistamines and corticosteroids may be added as adjuncts, but they do not replace epinephrine. IV fluids, volume expanders, and vasopressors may be needed to maintain blood pressure. For patients with asthma or bronchospasm, aminophylline or additional corticosteroids may be used to help open the airways. Even when symptoms improve after epinephrine, patients need to be transported to the emergency department. That's because of the risk of a rebound or delayed reaction that can occur 4 to 8 hours later. The observation time varies depending on severity, but longer monitoring is needed for patients who ingested the allergen, required multiple doses of epinephrine, had hypotension or airway involvement, or have a history of asthma. Now let's shift to the nursing role. Nurses are often the first to recognize anaphylaxis. Assessment focuses on airway, breathing, circulation, and vital signs. while watching closely for swelling or respiratory distress. The nurse must activate the rapid response team or notify the provider immediately, initiate emergency measures like intubation prep, oxygen, IV access, and medications, and document everything: what interventions were used, the patient's vital signs, and their response to treatment. After recovery, education is essential. Patients need to understand what happened, how to avoid exposure in the future, and how to use emergency medications. Every patient who's had an anaphylactic reaction should be prescribed an autoinjectable epinephrine device, and the nurse's job is to teach both the patient and their family how to use it. Here's what that teaching looks like. The patient removes the autoinjector from its tube, holds it with the orange tip pointing down, and removes the blue safety cap. They hold the device near the outer thigh, swing and jab it firmly until they hear a click, and hold it in place for about 10 seconds. After removing it, they massage the site for 10 seconds, then call 911 and get to an emergency room. The used autoinjector is placed needle first into its storage tube and brought to the hospital. Nurses should always have patients practice with a training device and return demonstrate the steps so they're confident. To sum up, anaphylaxis is a rapid, life-threatening allergic reaction that requires immediate recognition and treatment. Epinephrine is the cornerstone of care, supported by oxygen, fluids, and adjunct therapies. Prevention, patient education, and nursing vigilance are key to saving lives and preventing recurrence. That's it for today's lecture on anaphylaxis.